Hello, everybody. Corneal allogenic intrastromal ring segments, or also known as CAIRS. This is Shady Awwad from the American University of Beirut Medical Center, and I have no financial interest in the subject matter. PMMA segments have complications, and a not so uncommon complication of an otherwise perfect surgery is actually stromal melt, and it can come in different configuration, as you can see here. And sometimes what can look like a very innocuous epithelial defect, if examined more carefully using OCT, this defect can be seen to extend all the way down to the ring segments. And that can be deep stromal melt. Sometimes it's just thinning of the anterior stroma, as can be seen here with OCT, and that's typically also of stromal melt. A study by GCEO Awwad showed that that risk is about 7% over 10 years. Mostly those patients were done using microkeratome and hexagonal intacs. We have shown a similar risk of 5% using all Femto technology and Intax SK. So with the state-of-the-art procedure using the latest corneal rings, we still have a high risk of stromal melt that can develop years later. This also can lead to sometimes a complication of intrusion, typically seen in triangular corneal rings, typically with rubbing, that can intrude into the SMA's membrane, as can be seen here. And we can see also sometimes neovessels developing, especially in peripheral corneal rings or when the optical zones is large. That's why corneal allogenic intrastromal ring segments, also known as CAIRS, were developed so that some of these complications can be avoided. They're allogenic, so a lot of these melts and neovessels do not develop. For that, we usually take a corneal button, denude it from DSMAs and epithelium, trefine it using Jacob's trefine. We get a ring that we cut in equal segments using a super sharp. And then attention is to the patient's eye, where we mark the corneal vertex. We mark the horizontal meridian. We extend it using this marker. It's the Awwad corneal marker from Epsilon. And then as we have now the corneal vertex, the three-prong lines all pointing to the corneal vertex, we apply suction. And using the Femto technology, we align the planned treatment on the corneal vertex, both using the dot in the center, but also aligning the three prongs together, which is like a crosshair that gives us an idea where the corneal vertex is. Again, we rotate the planned treatment to the desired rotation, and then we proceed with Femto tunnel creation, as can be seen here. Now, using the Mickey instrument, we proceed in opening the incision. And using a mechanical dissector, I like to make sure that all the bridges are completely broken, if any. And that's why I like to make sure that I do that before introducing these segments, because these segments are pretty soft. They're not like PMMA segments, and I don't want to have any hurdle while introducing them. And then now we can introduce the segment, as can be seen here. Ideally, I like to pre-program an incision diametrically opposite to the main one, where I can pull the segment through using a Sinski or sometimes a micrograsper. Now, back to the segment which intruded, as you can see here. This segment was explanted, and then after that, we look at the topography before, and then the one after. Not much change has developed, and that gives an idea that the corneal ring segments didn't help much. It was deep already, and it wasn't helping much. And after the edema subsided, you can always see that the tunnel is still open into the aqueous, but after the edema subsided by about 2 months, I implanted a corneal ring segment, as you can see here, exactly at the location of the previous one. Now, interestingly, we could do it exactly at the exact location because we went superficial, and that's something very unique in these segments. We can go as superficial as 250 microns, as you can see here. The reason why, they don't melt. Regular PMMA segments would melt if implanted very shallow, but these are allogenic. We can implant them very superficial, and that's the advantage over regular PMMA segment. And by implanting them very superficial, we could go exactly at the same location. And now if you look at the topography after, as you can see here, by the way, we can calculate the arc length using cornealanalysis.com, and it's about 170. And that's exactly the arc length I wanted to debulk most of the cone. And postoperatively, you can see a major improvement both in Kmax and regularity and in cylinder. And if you look at the refraction and visual acuity, we have a whopping improvement in both CDVA and of astigmatism. And this is also can be seen by looking at the OCT refraction, corneal refraction, and the total corneal coma and trefoil, a major improvement. Again, at the optical quality, major improvement at the MTF. Now, the other complication with which is stromal melt, again, we have published an article using GRS where we have implanted a CAIRS segment at the site of the explanted PMMA. Now, this patient, the first eye, we didn't implant anything, and you can see that the patient developed corneal melt. The corneal ring segments was removed, and we can see a downgrowth of the epithelium all the way down, and we can see a thin cornea all the way down to the initial implantation, which is about 400 micron. Now, the second eye developed exactly the same complications, the stromal melt, but instead of removal, we just exchanged with CAIRS. And as you can see here, the CAIRS very nicely took or got incorporated into the stromal melt, and 3 months after, the cornea looked pretty good on OCT. And if you can look at the topography, the first eye where the CAIRS was where the PMMA was explanted, the topography got irregular, while the other eye, we can see that the regularity was maintained from after the PMMA segment was explanted, and the CAIRS was implanted instead. Now, for me, CAIRS was excellent in that terms, but it still lacked many features. One of it is customization, arc length, thickness, asymmetrical segment. It just takes a lot from the surgeon to do that all by himself or herself, and that's something that will sit against this procedure becoming widespread and widely adopted. Precision reproducibility. Depending on how we cut and the arc length we choose, we cannot make sure about the reproducibility of this procedure. And again, this stands against its widespread adoption. And that's why using an artificial anterior chamber and using the Femto LDV Z8, I worked with the Zimmer team to develop a software where we could cut these segments from a donor cornea using an artificial chamber, as you can see here. You can, using OCT, know exactly the depth, the location, and everything. And then you can cut the segment. You can use the cornea to cut another segment and maybe a third segment if possible. And as you can see, it's easily repeatable. With the Sinski, we delineate the cut, and then you can remove it very easily. Now, these segments look really nice on slit lamp as opposed to the PMMA. As you can see, it really can fit into the cornea because it's the same material. And this is the segment the same day post-op. Again, on OCT, they look very nice. And on slit lamp, again, the very well cut material looks and sits in the cornea pretty well. So my conclusion and thoughts about it. Now, CAIRS are definitely a breakthrough in terms of safety and in terms of providing more therapeutic options than their PMMA counterparts. Now, all Femto CAIRS or CAIRS performed using the Femto, both cut, refined, and implanted, provide definitely a promising tool for keratoconus treatment and management. They maximize customization. There's no need for inventory the way we do for PMMA segments in terms of arc length, segment size, and all that. They definitely introduce better precision and reproducibility because the cut is performed using the Femto. Second, the arc length, the segment size, all is pre-programmed. It can be definitely applied in iBank or in clinics alike. But I think what we need to develop from now on is better nomograms and better understanding about their mechanism of action, and hence provide some standardization. And this is what's going to drive this procedure to be adopted by all surgeons, whether they are refractive, cornea, or general ophthalmologists. Thank you.